This Week in Virology, the podcast about viruses, the kind that make you sick. From Microbe TV, this is TWiV, This Week in Virology, episode 1148, recorded on September 12, 2024. I'm Vincent Racaniello, and you're listening to the podcast all about viruses. Joining me today from New York, Daniel Griffin.
Hello, everyone.
I see on your bow tie, there's spikes. Okay, there's some virus on your bow tie, but I can't see it very close.
Actually, it's interesting. If you were to zoom in, this is actually my fungal bow tie.
Oh my gosh.
And so this is like a close-up of the canidia, and there's little spores. And
okay.
And the nice thing is you could sort of wear it different ways, so you can actually end up with it, so this is like a bow tie you can bring with you when you travel, and depending on how you put it on, it's got a lot of red and blue or a lot of green, so.
All right.
Yeah, I'm reviewing today, just coincidentally, after putting this on, I was reviewing fungal therapeutics and resistant genes and ergosterol and, the echinocandins and But let's get right into it. And actually, I guess speaking about red and green, quote from F. Scott Fitzgerald from The Great Gatsby. So we beat on boats against the current, borne back ceaselessly into the past.
I remember that very much.
Yeah, and it's interesting. I feel like I've even used this one before, but sometimes I feel this way.
Do you think that sometimes, we're just pushed back all the time?
Yeah, sometimes I feel like, as much as we try to move forward, like there's this current against us. You sort of have to reteach, no, this is what is actually true despite all this, effort to undo what we've learned. But all right, let's jump in with a little more optimism. Maybe optimism. I don't know if that's the right description for this first paper, but right up front, the article, Farmed Fur Animals Harbor Viruses with Zoonotic Spillover Potential. Maybe it was that harbor reference that got me thinking of The Great Gatsby, because actually in the book, right, Jay Gatsby is looking across our harbor right here in Port Washington. He's over there in Great Neck looking across Manhasset Bay at Port Washington, East Egg, where I live. And so this article, which was published in Nature, is a situation where the investigators performed single sample meta-transcriptomic sequencing of internal tissues from 461 individual fur animals that were found dead due to disease. They characterized 125 virus species, including, as they say, 36 that were novel and 39 at potentially high risk of cross-species transmission, including zoonotic spillover. What are you thinking so far, Vincent?
I love it. I think it's great.
All right. They identified 7 species of, what are we thinking? What coronaviruses? Oh my gosh, who's heard of those? And documented the cross-species transmission of a novel canine respiratory coronavirus to raccoon dogs and bat HKU5-like coronaviruses to mink, so bat to mink, present at high abundance in lung tissues. 3 subtypes of influenza A virus, H1N2, H5N6, H6N2, in the lungs of guinea pig, mink, and muskrat. Multiple known zoonotic viruses, such as Japanese encephalitis virus and mammalian orthorhinovirus in guinea pigs. Raccoon dogs and mink carried the highest number of potentially high-risk viruses, while viruses from the Coronaviridae, Paramyxoviridae, and Pseudoreoviridae families commonly infected multiple hosts. We got a nice, I like this map. They give us a map. This is China, right? China, Mongolia. And you can see the fur animals in all these different areas. I even like they've got this little close-up, right, where you can see the different animals, right?
I think many countries have fur animals, right? And so I think if you looked in any of those locations, you'd find viruses of some kind, right?
And it's interesting, right? Because there is definitely a lot of human interaction with these,
for sure.
fur
If you
animals.
remember, during the beginning of COVID, the mink farms in the Netherlands the minks got infected from humans, and it was spreading like crazy.
Mm-hmm.
And they culled all the mink in the
Yeah,
Netherlands. They got
yeah,
rid of them because it was a threat.
yeah.
But I think the point here is interesting that raccoon dogs, of course, were also sold at the Huanan seafood market for eating, and they are highly likely to have contained SARS-CoV-2. So you have to be careful with these animals.
Yeah, yeah. I mean, I think sort of as we keep talking about, I mean that I think at this point the preponderance of evidence really supports that there were infected animals that were brought to that market, and so the spillover into probably raccoon dogs or other animals that were then brought to the market occurred wherever they were being bred, right? One of these case not being farmed for their fur, but being farmed for their meat. And then you bring them to this place where then, you interact with lots and lots of people and then, comes across. So just another reason maybe why we shouldn't be, farming farming animals for fur. But I think the other, and this is really important, is this whole don't keep your head in the sand. Like they're right here. We've been saying for decades, the whole community of scientists, of virologists, of infectious disease specialists, that these pathogens of zoonotic pandemic potential, they're out there. They're there. The coronaviruses, the influenza viruses. And it's important for us to under and appreciate this because there's sort of this odd idea that, if the scientists don't look, Pandora's box will stay closed. But we're messing with these animals on a regular basis. The next one, we're moving into back into mpox. It been actually a lot, so I sort of had to select what I thought was the most important here. But the article "Comparison of Protection Against Mpox Following mRNA or Modified Vaccinia and Cara Vaccination in Non-Human Primates," published in Cell. So here the researchers used a clade 1 monkeypox virus, Zaire, challenge model to assess the protective efficacy of an mRNA lipid nanoparticle vaccine, mRNA 1769. Sounds kind of familiar, right?
It does. So I bet those are the amino acid numbers or something like that, right?
And so they're going to look, and they're basically going to say, how does this mRNA vaccine work? This mRNA vaccine is expressing optimized version of the 4 monkeypox viral antigens of interest, and that's A29, A35, B6, and M1. And they're going to compare this to the modified Vaccinia and Cara, right? So that's the Bavarian Nordic Jynneos vaccine, which is a replication-deficient vaccine, which expresses all the viral antigens, protein, nucleic acid-based vaccines. The animals received either the MVA, right, or the mRNA 1679, and all the animals were completely protected from lethality of infection. 5 out of the 6 in the PBS group succumbed to infection. Now, what they're really going to basically contrast is the lesion number. So we're going to see a little bit difference here, fewer lesions with the mRNA vaccine compared to the number of lesions that we saw with the Bavarian Nordic, the Jynneos vaccine. They do point out that there was a little bit of duration of disease reduction as well, but a few limitations they point out. Because it was really interesting, sort of watching this, Bavarian Nordic stock goes down because now there's an mRNA alternative, and look, it's a little bit better. But they point out, a couple things I'll point out. One is they point out that we don't know about longevity, right? So, this is sort of short follow-up. So is this going to be, because what we really want to do, right, and this is sort of the smallpox history, the Jynneos history so far, is we really want to give this vaccine maybe as a 1 or 2 dose and then be done with it, right? So will this have that durability, what we think is decades? The other is cost, right? I mean, right now, this is sort of a vaccine that has a certain cost. Is Moderna going to come in with an mRNA vaccine for mpox that's actually going to be less expensive?
So Daniel, there still were lesions in these animals, right? There were.
Yeah, there still were lesions. They still saw lesions, and it was really, when they compared the number of lesions, it was about a 90% reduction, right? So the MVA, so the Jynneos immunized animals, they got up to a maximum lesion count of about 600, where the other animals ended up with a peak lesion in the 50s, right? So you did see a reduction in the number of lesions.
It may still allow transmission. It may.
I think it does allow transmission. Yeah, once you're getting lesions, we would think that there's. But that would have been great, right? That would have been I would have loved that part, And then we took these animals and put them in, with other animals. I mean, I know with primates that's a really expensive ask, but maybe you could have even just gone ahead and done, some plaque assays, right?
Yeah.
Does the mpox virus? Does the monkeypox virus plaque?
I'm sure it does. Yeah.
Yeah.
The measles vaccine does prevent lesions, correct?
So it's great at preventing lesions. And then even if someone with measles gets some degree of disease, we've talked about, there's about a 400-fold reduction in the transmission. So, yeah, because that would be a great thing because we're trying to control an outbreak here. So, you could say, oh, this vaccine may cost twice as much, but it blocks transmission. That's huge.
So the MVA, does it prevent lesions at all? Do you know?
So we still see people who post-MVA vaccination still get clinical disease. They still get lesions, right? So there is that phenomenon. They tend to get less disease. They tend to get fewer lesions, and they end up with a really big impact on severity, right? So I think in the study that we saw that was down in the DRC, down in Africa, we actually saw no one ended up hospitalized if they got vaccinated.
Mm-hmm. Okay.
So yeah, so a lot of interesting stuff going on there. Briefly, the article, A Cross-Sectional Evaluation of the Virtual Outpatient Management of People with mpox, published in Open Forum Infectious Disease, right? So can we just use telehealth? Should we use telehealth? Can we successfully do that? So this is actually a description of the successful use of telehealth to manage mpox. And I will point out, we really use this model heavily during the early days of the mpox. Actually, just to describe our experience. So what we would do a lot of times is we work closely, the urgent cares, other providers in the tri-state area for access to the tecovirimat or the TPOXX and enrollment in the STOMP trial. There was one required in-person visit that we would coordinate. So here, among confirmed cases, an N of 221, 86% were managed exclusively on this virtual ward, as they call it. 14% did require admission. Treatment for concomitant sexually transmitted infections was provided to a quarter of the patients. Antibiotics for other infective complications, about 16%. Some symptomatic relief, 27%. And they actually conclude, and I agree because we had the same experience, that this virtual ward model facilitated safe and holistic outpatient management of mpox while minimizing admissions, and really serves as a model for future outbreak responses.
And whenever you say tecovirimat, I think of the automat.
Yes.
Do you remember those?
Oh, I do. Yes. But yeah, no, I think this is great. I mean, people bemoan like, oh, we're less prepared for the next pandemic than we were going into this last one. But actually, I have to say that the real ramp up of telehealth facilities, the idea that you can actually take care of folks at a safe distance, and here, right, we're orchestrating the diagnosis and treatment of other sexually transmitted infections. There's antibiotics, there's symptom care. We're really minimizing the number of people that actually need to end up in a hospital. So really minimizing the burden on our acute care facilities. And that was a big issue, right? I didn't cover the article this week, but they actually predicted about 20% or suggested about 20% of the deaths during the first year of the COVID-19 pandemic were due to the facilities just being overwhelmed. So if we can somehow mitigate that.
Also, in this case, not going to have in-hospital transmission, right? Which is a big problem.
That's a huge issue, right? Like, because you have an individual with mpox, they end up in the hospital. How are you going to deal with keeping them safe? You're tying up that room, preventing in-hospital transmission. And unfortunately, we still to this day, someone shows up in the hospital for something else, but someone is there admitted with COVID, and now that person gets COVID. So in-hospital transmission is a challenge. All right. This is a letter that, I say people send letters, they send it to me personally. They send it to PWB. They send it to Daniel@microbe.tv, right? That's what they're supposed to do.
Correct.
They also send it to somewhere else, which we won't mention because they'll send them there. So here was a letter sent to Parasites Without Borders. Dr. Griffin was asked by a listener where to refer patients for mpox vaccine. I was surprised he did not advise the listener to contact the NYC Health Department, the first place to turn to. However, for patients in New York, State Health Commissioner James McDonald has issued a statewide standing order allowing pharmacists to administer the 2-dose mpox vaccine without a doctor's prescription. The Department of Health announced Friday, I'm not sure which Friday this was, my standing order allows individuals to get their JYNNEOS vaccine from a pharmacist without seeking a physician, greatly increasing access to this important layer of protection as we remain vigilant and continue to monitor mpox in the United States and abroad. McDonald said in a statement, pharmacists are an important component of our overall healthcare system and remain a center point of accessible care in our communities. So I'm going to actually say thanks to our listeners and this person, and we'll put in our show notes a link to the NYC Health and Mpox Finder. It's really, there's basically an vaccinefinder.nyc.gov. You go there. It's interesting. There's two sort of panels. One is finding the mpox vaccination, and then that has a robust list of places that have it. Phone numbers, addresses, the rest. And then there's another tab for COVID vaccine, and that gives you a blank page. So just saying. All right. And a little bit more on RSV. This really seemed timely when I was quoting some of the trial data last week. And this is the article, Nirsevimab and Acute Bronchiolitis Episodes in Pediatric Emergency Departments, published in the journal Pediatrics. And so this data from Spain. And so back in the 2023-2024 RSV season, right, so that's the last year, Spain became one of the first countries to introduce the universal RSV prophylaxis, right? So that's the Nirsevimab, the Beyfortus, that you're getting the monoclonal antibody. Locally, most Spanish regions also immunized infants younger than age 6 months at the start of the season, this extended catch-up. And the aim of this study was to assess how RSV prophylaxis affected the number of infants presenting to pediatric emergency departments with acute respiratory infections. A retrospective study was conducted in 15 Spanish pediatric emergency departments from 9 different regions. And so here we have actually the published study published in Pediatrics. And a comparison with the average rates for the previous epidemic seasons revealed a 57.7% decrease in episodes of lower respiratory tract infection in 2023-2024, a 59.2% decrease in episodes of acute bronchiolitis, and a 63.1% reduction in acute bronchiolitis-related hospital admissions, a 63.1% reduction in pediatric ICU admissions. So just really some good real world data about the efficacy we saw here.
Daniel, they don't look at deaths at all, or is this not an issue?
I think the death rate tends to be so low that they're focusing on larger numbers. You'd end up with a really wide confidence interval.
Good.
Yeah, I think in our entire country, right, in the U.S., we see, I think the number is 100 to 300 deaths per year, right? And so you look at a country, you're going to see just a handful of, single-digit deaths in Spain from RSV each season in the pediatric population.
And presumably Nirsevimab will prevent that, right?
You would think, well, the majority of deaths it should prevent.
Yeah.
So yeah, exciting. All right, and COVID, Vincent. Have you heard of COVID?
I have.
So looking at our map, what stands out to you?
We had this incredible peak at the end of the summer, right? Which was unprecedented in the previous summer. And now it looks to me that it's going down.
Yeah, so the wastewater data is going in the right direction, right? It seems to be coming down. But, our late indicators, that's what we're seeing now. So that we may be off the peak. And actually, the peak in some areas was as high as it was last winter, actually. Interesting how high it was.
But there was not an August peak last year.
It wasn't quite the...
Very interesting.
Yeah, so...
Well, I'm on record as saying this will replace the winter peak. We'll see.
Yeah, we're going to see. We'll be here. You and I will be here in January. And the COVID deaths, right? So in the hospital, we're seeing we're still seeing a large number of people in the hospital and deaths, right? And this weekly, we're actually seeing Georgia has got into that 4 to 6% of all the deaths in Georgia are due to COVID. Kentucky is still there. New York, actually, I say majority, probably about half the country, 2 to 4% of all the deaths we're seeing right now are COVID-related deaths. But we're expecting that to trend better in the coming weeks. Yeah, unfortunately, I'm hearing news from the universities, right? They've got their pledge week, their rush week. I think they give it a new name now, but lots of COVID at our university campuses. The variants, KP 3.1.1 is taking the lead. I think it's like 40% up here in the Northeast, but pretty moving across the...
JN is nowhere to be seen.
Yeah, I always like to keep my lineage in mind. Like, so, the JN.1, which is really sort of the parent of this lineage of the KP.3.1, that's basically, we're not really seeing, it's like less than 0.3% across the country, the JN1.
And so we could call all of these the JN.1 clade, right, Daniel?
Yes, as we talked about on our live stream. So we're now seeing JN.1 clade taking everything over. And yeah, this is all JN.1 clade. All right. And vaccination, right? I'll make sure at the very end of this just to sort of give some updated recommendations. I just keep getting asked those. It makes me wonder if perhaps my close family and friends are not all listening to our weekly update. So the article, I have to say, Vincent, I found this really interesting. So hopefully we can have a little discussion about this. But it was the article, association between SARS-CoV-2 viral load, we should call that RNA copy number, by the way, and COVID-19 vaccination in 4 phase 3 trials published in JID, the Journal of Infectious Disease. So for this analysis, 4 randomized placebo-controlled phase 3 COVID-19 vaccine efficacy trials were really included, right? So we've got, we'll go through what we're looking at. So we're going to look at the mRNA 1273, right? So that's the Moderna mRNA vaccine. That'll be our mRNA representative. We're going to look at the AstraZeneca and the Janssen vaccines, right? So that's going to be our chimp adeno and our adenovirus vaccines. And we're going to look at Novavax, right, which is our protein subunit vaccine. And what they're going to do is they're going to look here at they say viral load, but the RNA copy number, so copies per ml, and they're going to compare. So these are people who end up getting an infection who either got each specific vaccine or they got a placebo. Right, so these are the these are these placebo-controlled phase 3 vaccine trials. So this is data from a little bit back that they're now analyzing here, and so I'll go through it a little, and then we can talk about it. So they talk about the estimated vaccine effect on the RNA copy number. And you can actually see the estimated vaccine effect on RNA copy number. You're using kind of almost as baseline, pretty similar to placebo, your Janssen and your AstraZeneca. But then you see about a 3 log reduction with Novavax. You see about a 2 log reduction with the mRNA vaccine.
So many questions, Daniel. I mean, first of all, what's the match between the vaccine and whatever is circulating, right?
So it's the same, it's the same point in time, right? And we're looking at a reduction 2 to 3 months following the last vaccination.
Okay, so these were the original vaccines, right?
So this the original vaccine efficacy trials.
And roughly when were these data collected? This would be 2021?
Really 2020, 2021, right? So this is,
Okay. Yeah, well, and the other thing is this is RNA copy number. I don't know what this means, right?
That's,
I would like to know the infectivity. It's not so hard to do, right?
Yes. Yeah.
So it's clear there is a reduction. It's better with Moderna than any of the others. Novavax is pretty good too.
Yeah, Novavax, there's overlap, right? So I don't want to oversell, right? It's like, a 2.1 versus a 2.78 for Novavax. So Novavax, has a trend towards a little bit better, but, really overlapping confidence intervals, right? So, but really compared, like statistically significantly different compared to the AstraZeneca or the J&J.
But nevertheless, AstraZeneca and Janssen were clinically significant protection against severe disease, right?
Yep.
So it tells me that doesn't mean anything, maybe.
Yeah. I mean, part of the discussion they had was, is this important for onward transmission, right?
Well, we don't know because, first of all, we don't know what the reduction in infectivity is. And even if we did, we don't know how much you need to transmit, right? That's always again,
like, is the threshold. Like if you're above the threshold, I only got shot once in the chest, right? Like, it doesn't matter, right? That's enough, right? And that's the issue, right? I mean, it's a binary with you got infected. We don't think there's a dose to like, oh, but I got really infected. And
there's this challenge trial in the UK where they give people 10 to the 5 TCID50 or whatever, right?
Mm-hmm.
They pipe better right in their nose. They put a paper clip on their nose. That's not natural transmission. So I think those numbers are irrelevant, right?
Yeah, that's also tough too. Yeah, I mean, here, what would be, say, more interesting to me, and we'll actually mention this in one of the other studies we're going to talk about, is what if you look about secondary cases, right, in households?
Yeah.
Right. So, I mean, they could have gathered that, I don't know if they were set up to do that, but I would love to know, okay, 2 to 3 months later, the different people got the different vaccines. What were the secondary attack rates in those households?
Mm-hmm.
That would be even more compelling for me. All right. So passive vaccination, remember PEMGARDA, and we'll keep a link to the PEMGARDA.com infusion center locator. COVID early viral phase, right? So we have the NIH and the IDS guidelines, but I am going to start off with the article, Health Outcomes 3 months and 6 months after molnupiravir treatment for COVID-19 for people at higher risk in the community. Panoramic, a randomized controlled trial published in the Lancet Infectious Diseases. So here are results. They're not really the results, but they're results from the extended follow-up of the Panoramic trial, right? So we had the early results, and now we have the follow-up results of Panoramic. So Panoramic was a randomized controlled trial to evaluate the effects of early antiviral therapy on long-term health outcomes at 3 months and 6 months after randomization. So this extended part of the Panoramic, this is part of that multi-center primary care, open label, multi-arm, prospective randomized controlled trial conducted in the UK. The participants were eligible if they were really eligible for treatment, right? So you had to be aged at least 50 years or 18 years with a comorbidity, unwell, and 5 days or less with confirmed COVID-19 in the community, right? So it's not hospital. This is in the first 5 days. In this study, participants were randomly assigned to the usual care group or molnupiravir group plus the usual care, and that was molnupiravir 800 milligrams twice a day for 5 days. And so they the results of this, it was a pre-specified analysis, not just going back and data mining. We actually see that people who were randomly assigned to molnupiravir, so early antiviral during the acute phase of COVID-19, had better outcomes at 3 months and 6 months. And what were those better outcomes? So a lot of this was questionnaire related. So in general, they related better well-being. Remember, this is blinded. So well-being, fewer and less severe COVID-19 associated symptoms, less visits to the doctors, less healthcare utilization, less absenteeism from work or study, and an overall on the scale they're using improved quality of life. So the conclusion based on this data is that and this was mostly a vaccinated population, by the way, in a vaccinated population, people treated with early antiviral therapy, in this case molnupiravir, for acute COVID-19 felt better, experienced fewer and less severe COVID-19 associated symptoms, accessed healthcare less often, and took less time off work at 6 months.
Daniel, is the implication that this is impacting long COVID because of that?
That's basically what this was. This was a trial looking at long COVID, so 3 months and 6 months. We're actually seeing, more data, sort of a growing body of data that early antiviral therapy provides a benefit for folks in terms of long COVID.
So
and a lot of it's
vaccination does, and on top of that, even if you're vaccinated, take an antiviral, and that'll add to it.
Yeah. Yep. All right. So what are the recommendations? Number 1, Paxlovid. Number 2, remdesivir. 3, molnupiravir. And in some cases, convalescent plasma. All right. The COVID early inflammatory week, just reminder, right? This is that bad week. This is when the viral replication is on the way down, when we're starting to see the inflammatory phase, steroids at the right time in the right patient, anticoagulation guidelines, pulmonary support, remdesivir still in the first 10 days, and in some cases, immune modulation. We don't do a lot of that here in the U.S., but I was surprised in Taiwan. That's really a part of the standard that they do. And, and we have discussed the data on that. All right, and I'm just going to wrap us up here with what I thought was really another microbiota alteration article in our long COVID section. And so this is the article, Adult Outpatients with Long COVID Infected with SARS-CoV-2 Omicron Variant, Part 1, Oral Microbiota Alterations. I'm waiting for Part 2, I guess, published in the American Journal of Medicine. So these results are from a prospective nested case control study that evaluated the differences in oral microbiota in individuals with or without long COVID, symptomatic and asymptomatic groups. Where's Michael Schmidt? They were assessed with 16S ribosomal RNA sequencing on tongue coating samples. 108 patients were included. There are 54 in the symptomatic group. The symptomatic group had, interesting enough, higher diversity and microbial dysbiosis with increased diversity and relative abundance of pathogenic bacteria. And these would be the Campylobacteriata, the Correlates, the Pseudomonadales, and the Campylobacteriales. So, the real challenge, I have to say, is they keep changing the names, and some of the names are so darn similar. You're wondering, did I say that twice? But they found out that these particular marker bacteria were associated with long COVID symptoms. And really interesting is that there were distinct variations in the oral microbiota between COVID-19 patients with and without long COVID. So sort of a discriminatory finding here.
So the question is whether these patients had dysbiosis before long COVID and it predisposed them to it, or if this was a consequence of long COVID.
And whether messing with this can have a benefit for folks with long COVID, right?
I mean, it's funny that it's just the oral microbiome, right? Because the gut is another big one.
I don't think it's so much just as we're finding it here too, right? Because we have some studies that there's a gut microbiome dysbiosis associated with long COVID. Well, I suspect there's also a skin microbiota as they were seeing your oral. So
even a brain microbiome.
Actually, that would be really interesting, right?
Yeah. It's there.
Yeah, there is a CSF microbiome. All right. So as we've been saying for a while, actually 4+ years, no one is safe until everyone is safe. Appreciate all the people who jumped on the office hours live stream that we did last night, that Vincent and I did last night live, jumping on and helping support the work that we do. But I'm hoping a number of you will pause the recording right here, go to parasiteswithoutborders.com and click donate. Every bit helps. We're in the middle of our Floating Doctors fundraiser, where August, September, and October will double those donations up to a potential maximum donation of $20,000.
It's time for your questions for Daniel. You can send yours to daniel@microbe.tv. Okay, so this first letter has the rebound word in it, Daniel. So we're going
my
to,
gosh.
all
Yes.
right. Robin writes, any updates on possible longer courses of Paxlovid? I saw Paxlovid's data that a longer course in immunocompromised patients lowered viral load and prevented rebound more effectively than a 5-day course. Would it make sense that a longer course for everyone would do the same? And would it be more effective at decreasing post-acute problems potentially by further lowering viral load? Oh my gosh. Thoughts?
All right. So you got all the little catch things in there. So so let's start off first with, and I mean sort of a request. So, we always harped when people talked about efficacy. You said, well, what kind of efficacy? What are you talking about? So when you say rebound here, are you talking about symptoms? Are you talking about RNA copy number, going from 10,000 to 100,000, but not up to millions? And so that's one of the things I guess I'll first mention is a lot of doctors will say, I see my patients and, 20% of my high-risk people, they have this rebound. And I would say no, they don't actually have rebound. They have symptoms during that second week. And symptoms during that second week do not correlate with RNA copy number. And RNA copy number during that second week does not correlate with symptoms. So what really is rebound and what is the point? As we talked about too, are you thinking like, oh boy, if I treat everyone for 10 days, I'm going to keep that RNA copy number down below transmission? We don't see transmission in that second week. So you're really not going to accomplish any sort of impact on transmission. Two, as I mentioned, there's no correlation there between that RNA copy number during that second week and symptoms. So you're not going to get symptoms any better by treating people for 10 days versus 5. If anything, you give them an extra 5 days of, whatever potential side effects they might be having, another 5 days of being off the medicine. So, you got to really ask, what is my goal? What am I trying to accomplish? It makes everyone feel good to have a negative antigen or a low RNA copy number. But is it worth it? In my days when I was in medical school, we still were treating people with pneumonia for 21 days with antibiotics because we wanted them to be, quote unquote, all better before we stopped. We now know that was actually harmful. That's how you breed resistance. That's how you cause problems. So that would be the first. And as you mentioned, lowering viral load. We're not measuring virus. We're just measuring RNA copy number. And RNA copy number, as we're saying here, once you get out to this latter part, right, past day 7 or 8, you're below transmission anyway. So,
Okay. Fruka writes, I was wondering whether you could speculate on whether there may be a link between the IgG4 class switch observed after a third dose of mRNA vaccines and the reduction in the risk of long COVID after the booster. I understood that IgG4 is less inflammatory than IgG1 to IgG3, and that a similar class switch in beekeepers seems to keep them safe from an anaphylactic shock. As long COVID seems to have an autoimmune component to it, could more IgG help prevent long COVID?
I don't know. So, it's really interesting. There's certainly a lot of people out there who think they do know. This is interesting. And there's certain autoimmune diseases that are IgG4 autoimmune diseases. There's this interesting phenomenon that you describe where there's actually, the IgG. So sort of give an overview. So the antibodies or immunoglobulins, we have different classes, right? So we've got IgE that's involved in, let's say, allergies and parasite clearance. And we have the IgM, right? That is sort of our first antibody that we make. We have an IgA, which we think of as a mucosal. We have our IgG. That's really the bulk of our antibodies. And then the IgG has 4 subclasses. So IgG 1, 2, 3, 4. And then there's even like, within the different ones, there's the different like IgG, 2A and B, et cetera. So there's a lot of different variety here. One of the things that was noticed at one point was this elevation of IgG4, this class switch observed after the 3rd dose of the mRNA vaccines. And so some of the anti-science people jumped in. Oh my gosh, this is the harbinger of doom. This is the worst thing in the world. We really have seen nothing negative here. But it is interesting. We have seen that repeated vaccinations can be a therapeutic for long COVID. So this is interesting speculation. Maybe what they were seeing as a potential warning sign, maybe that repeated vaccination, maybe this is a potential thing to look at. Maybe we are modulating some of that immune dysfunction by modulating the different IgG subclasses. But this is all speculation, and we need to do the science.
Lori writes, I'm a 62-year-old female, day 9 after SARS-CoV-2 infection. Symptoms were sore throat, achy body, tired. I started Paxlovid day 3. I started having periods of nausea around day 4. And by day 7, nausea was all day. I started having abdominal pain. Pain is now constant enough to keep me awake. Acetaminophen helps. I read that it's not uncommon to have GI symptoms after COVID. How long can I expect this to last? I've started on a clear liquid diet to help with symptoms. Is this a good idea?
Yeah, so this is a challenge, right? A lot of times, during the first week, you can have GI symptoms as part of acute COVID, and GI symptoms can continue. There was this idea early on that, people only had respiratory symptoms, they didn't have GI symptoms. I remember starting to ask patients, and they all had GI symptoms, but they're like, yeah, but that's the least of my problems, Dr. Griffin. I can't breathe. So GI symptoms are actually quite common during COVID. They're often overshadowed by other symptoms, but in some folks, no, that's the biggest issue. The first patient I saw with acute COVID at one of our hospitals, this is back in early March, came in with diarrhea, no respiratory symptoms. Now, in some folks, that can continue past the acute period, past the 7 days, past the 14 days, even a little bit longer. What you're doing is great. Just take it easy, clear liquid diet, advance that slowly. And in most cases, this should resolve. And I hope that's what you experience.
Lori writes, I'm a pediatrician and I often have to get Hep B titers on young adult patients who are applying for nursing school or similar, or I am testing due to high-risk sexual behaviors. Increasingly, more of my patients are seronegative, and I offer them the option of redoing the 3 vaccines and not retesting, or giving 1 vaccine and retesting. Some programs require the 3 vaccines and then testing, although I don't know what they'll do with the non-responders. I've always been taught that the memory T cells would kick in with a new exposure and not worried too much about the serology, although the school programs do. Now I'm beginning to wonder if that may not be true, and perhaps I should be screening all my young adults for Hep B serology when I test their lipids and other young adult labs. Are these young adults protected? What are your thoughts? Have you found that many of your patients are non-immunes when you test their Hep B serology?
So, I'm one of these, sort of over time lost my Hep B titers, right? So, when I was back in medical school last century, one of the ways you could make extra money was sign up to get vaccinated and get your blood drawn. And so hepatitis A, hepatitis B, anytime there was a vaccine, I was there. So yes, hepatitis A and hepatitis B, I was one of those early, testing the different regimens. And then, decades later, my serology tests were negative and, shot after shot after shot, they're still negative. And so, we do think that it's T cell mediated, so I'm not sure I really understand this, me getting a completely another series and again, but yep, this is what they do. But don't let the fact that, an administrator or program requires the serology testing and these repeated shots to change your understanding of immunology.
And Russell writes, my wife and I are in the midst of a bout with COVID, which was confirmed by a rapid test. We were planning to get the latest vaccine a couple of weeks before we travel to Norway to visit our granddaughters, lower the chance of infection and transmission there. Now, according to the guidelines, We will not need to be vaccinated for that purpose. I'm not sure we would have tested were it not for the decision around timing the next vaccination. Would you consider this scenario as a rationale for testing while symptomatic, that is, timing of vaccination?
Yeah, so I mean, I think there are several reasons why you might want to test when you think you might have COVID. So one is, yeah, this, am I getting a boost and should I be delaying that vaccination by 3 months, which I think makes sense, right? So if you have COVID right now, then you're going to delay. You can say, okay, I'm going to wait 3 months before I get my new vaccine this fall. The other is, right, if you might be a candidate for treatment, you might say, oh, I want to test to see if I'm going to, potentially benefit from treatment. And then the other is, right, you want to know about potential transmission risk to others. So yeah, this makes a lot of sense.
That's TWiV Weekly Clinical Update with Dr. Daniel Griffin. Thank you, Daniel.
Oh, thank you. And everyone be safe.